So hello and good afternoon. Welcome you all for this CCR presentation from the Department of Geriatric Medicine. So here we are presenting a very interesting case with a very atypical presentation in this our age group, the geriatric age group, and also we'll see how sometimes rare diagnosis can be missed if we don't have the index of suspicion in the older patient just because of their age. So let's start with the case now.
Good afternoon, respected faculties and my dear colleagues. Let's see our case. So, we have a 65-year-old male patient who's a resident of Nepal. He's priest and vegetarian with no previous comorbidities, admitted to us with complaint of weakness in both legs for past 1 year. There was complaint of difficulty in walking for 1 year with complaint of weakness while lifting his arms for past 8 months. In history of presenting illness, so the patient was apparently normal. For 1 year, he was maintaining his activity of daily living, and then he developed history of weakness in both legs for past 1 year. It was insidious in onset, progressive in nature, started with difficulty in climbing stairs, and gradually it progressed to take help from others for getting up and sitting on bed. It was not associated with any muscle stiffness or joint pain. He was also having history, difficulty of walking on his own for 1 year, and it was insidious in onset, progressive in nature. It started with difficulty in walking for long distance, and slowly it progressed to difficulty in walking even for small distance. And then he started using walking aid to go outside his home for past 6 months. History of weakness was there while lifting his arms for past 8 months. It was insidious in onset, progressive in nature. It started from his right hand and slowly progressed to left hand. He was having difficulty in combing and bathing, and then he was not able to lift his arms. It was not associated with muscle stiffness or joint pain. There was history of difficulty in turning side to side in bed for past 10 months, along with history of occasional muscle cramps for past 10 months. Seeing his negative history, we were not having any history of distal muscle weakness, nothing suggestive of sensory involvement. There was no history of any muscle stiffness and no history which would suggest cranial involvement. There was no history of loss of weight or loss of appetite, and it was nothing like no history of fever, joint pain, or rashes or any trauma. There were no history of memory impairment and nothing which would suggest autonomic symptoms, and also no history of episode of dark unit. Looking at his past history, the patient had no known comorbidity. He had history of low back pain with radiation to bilateral lower limbs for past 6 years. There was history of pulmonary tuberculosis in 1983, for which he took ATT treatment for 9 months. And then he never got infected with COVID-19 and has received both his vaccines. There were no history of any recent surgery or blood transfusion, and no history of any drug intake for long time. His personal history: he was taking vegetarian diet with normal appetite. He was non-alcoholic, non-smoker, with normal bowel and bladder habit. No history of any drug allergy, and with normal sleep habits. In family history, so no history of any other family member with the similar complaints. And occupation wise, he was priest in temple with no history of any exposure to toxins. Geriatric specific history was absent in our patient. He was evaluated in Nepal in a hospital in which MRI spine, LS spine was done with bilateral hip joint, and it showed lumbar spondylosis along with disc desiccation, along with L3, L4, and L4, L5 subfacetal space stenosis. And there he was treated with analgesics, but there was no improvement. And then he was referred to AIIMS for further evaluation. Here's his MRI report. So summarizing our history, so we had a 65-year-old male patient with no known comorbidity, He had history of weakness in proximal upper and lower limbs, along with weakness of truncal weakness. There were a history of occasional muscle cramps and no history which would suggest sensory or autonomic symptoms. And he was non-alcoholic, non-smoker. There was no history of any drug intake, wrong drug use. So with our summary, we can anatomically localize our lesion to nerve and muscle disorder, which would give us the differentials of motor neuron disease along with pure motor neuropathies like diabetic amyotrophy, CIDP, multifocal motor neuropathy, and acute intermittent porphyria, with myopathies like inflammatory myopathies, metabolic myopathies, endocrine myopathies, along with muscular dystrophy, most likely limb girdle. We have ruled out limb neuromuscular junction disorders along with mitochondrial myopathy because of absence of any ocular movement involvement, and there was no history of fatigue or exertion also, and all obviously toxic myopathies have been ruled out. Moving forward with examination, in general physical examination, patient was vitally stable and head-to-toe examination in our patient was normal. In systemic examination, we'll start with CNS examination. So higher mental status of the patient was normal with intact memory, and there were no percussion, action of myotonia or paramyotonia seen, and no fasciculations were seen. In cranial nerve examinations, all cranial nerves were found normal with normal extraocular movements and normal facial expressions. So both of these were not involved. Moving forward with motor examination, we found that the patient's muscle bulk was equal on both sides, and very predominantly patient was having hypertrophy of calf muscles in both the lower limbs along with bilaterally symmetrical winging of scapula. And his muscle tone was normal on both sides, and cervical spine movements were also found to be normal. Coming to his muscle power examination, we can see that his power was reduced bilaterally in shoulder joint movements, along with reduced power in bilateral hip joint movements. Otherwise, the distal joint movements were found normal. And truncal examination also, the truncal extension and flexion were reduced power, and pelvic elevation power was also reduced. And Beaver sign was absent in our patient. His superficial reflexes, the abdominal reflex and thoracic reflex were found normal, and plantar reflex was flexor bilaterally. The deep tendon reflexes were preserved in our patient bilaterally. In his sensory examination, the superficial, deep, and cortical sense examination was found normal. Cerebellar signs were normal, and there were no signs of any meningeal irritation, and the Romberg's test was found negative. So seeing the posture and gait, the patient is having a very predominant lordotic posture with waddling gait. It was broad-based, symmetrical, with normal arm swings. There were no turning, freezing on turns, and no walking aid being used. Other system examination was found to be normal. Coming to the musculoskeletal examination of our patient, so there were no skin lesions, no ulcerations or eruptions were seen, and it was normal temperature. There were no wasting of muscles, only hypertrophy of bilateral calf muscles was seen, with no tenderness to palpation, and no joint deformity or crepitations were found. After examination, we did the comprehensive geriatric assessment of our patient, in which we found that the patient's basic activity of daily living was impaired, and patient was in a pre-frail status with adequate social support. Rest of the assessment was normal. So summarizing our findings now, we had a 65-year-old male patient with no known comorbidity. He had history of proximal upper and lower limb weakness along with difficulty in walking. He had history of muscle cramps, and on examination we found that there were bilaterally symmetrical winging of scapula along with hypertrophy of calf muscles with reduced power in bilateral shoulder and hip joint movements and reduced truncal movements power. And the reflexes were preserved, other examination were normal, and patient was in pre-frail status with impaired activity of daily living. So now we can narrow down our diagnosis, differential diagnosis to motor neuron disease. We can rule out CIDP and acute intermittent porphyria with preserved reflexes and other examination, and most likely myopathies. So now, because of the examination findings, we can see that muscular dystrophy becomes a more likely diagnosis about which we were not thinking earlier. So moving forward, we revisited our patient's family history, and with the pedigree analysis, we saw that none of the other family members were affected. Moving on with the investigations, the routine investigations were found normal with normal ESR and CRP. His creatine kinase was mildly elevated, 600 units, along with normal vitamin D. Thyroid profile was also found to be normal with normal serum cortisol. His myositis profile was found to be negative with negative ANA and KNRF factor. Moving forward with the nerve conduction study, and EMG was done to differentiate between the nerve and motor disease. We found that nerve conduction study was normal in our patient, and the EMG very specifically showed polyphasic motor unit action potentials, which were of short duration, small amplitude, and with full interference. And there were absence of spontaneous activity. So now this was suggestive more of myopathic pattern and less of inflammatory myopathy. So now we can narrow down our diagnosis more towards muscular dystrophy with a differential of inflammatory myopathies, and safely can rule out other differentials. And then to confirm our diagnosis, we would move forward with muscle biopsy. Now I would like to call our colleague from pathology to explain us about the muscle biopsy findings.
Good afternoon, everyone. Coming to the muscle biopsy basically shows there is, as you can see, there is loss of fascicular architecture, and there are variable sized muscle fibers. Like this one is bigger, this one is smaller. All everywhere there are variable sized muscle fibers. Then also there is endomysial and perimysial fibrosis. Some internalization of the nuclei, like the nucleus is coming inside, and also degenerating muscle fibers, like the small round ones. These are the degenerating and regenerating muscle fibers. So all of the features, these are the characteristic features of muscular dystrophy. So we did immunostain. So dysferlin, alpha sarcoglycan, beta sarcoglycan, gamma sarcoglycan. So all of them shows normal pattern. Then we did NADH-TR, so that it shows characteristically these are the lobulated muscle fibers. The small ones, they are called then show targetoid appearance. These are the lobulated muscle fibers on NADH staining, TR staining. So these mostly these confirmed. So it is probably a limb girdle muscular dystrophy. So again we did immunoblot staining. So it showed like normal dysferlin band and partial loss of calpain. So this is the normal dysferlin band we see here. This is the normal this is our case. These are the other cases. This is the normal dysferlin band, and this is the we see paint staining of the calpain. This is normal calpain, and this our case shows that this one partial loss of calpain. So it was normal band of dysferlin and partial loss of calpain. Finally, we made the diagnosis of calpainopathy.
So as we can see, our final diagnosis becomes limb girdle muscular dystrophy, most likely calpainopathy, along with degenerative spine disease and in patient with pre-frail status. So in this disease, our main management plan goes to be physiotherapy. So now I would like to call our a colleague from physiotherapy department to explain about the exercises and management for this patient.
Good afternoon, everyone. The patient was made to do active ROM exercises, maintain the mobility. Strengthening exercises were done for bilateral upper limb, lower limb, and trunk muscles. The exercises include for upper limb, arm raises, shoulder exercises in sideline, scapular protraction and retraction, elbow flexion and extension. For trunk muscles, bridging, tilting, rotations, and static abdominals were done. For lower limb, high sitting hip flexion, dynamic and static quadriceps exercises, and hip abduction in sideline was done. Patient was discharged on home exercise program. The video shows the current status of the patient. Now I request Dr. Bhavna, SR Geriatrics, to talk about review of literature.
Thank you. Good afternoon, everyone. I'll be presenting review of literature under following. As our patient had predominantly proximal muscle weakness, our initial differentials were polymyositis, dermatomyositis, limb girdle muscular dystrophies, metabolic myopathies, endocrine and toxic myopathies, and limb girdle muscular dystrophies. Because there was no facial involvement, we excluded facial and scapular winging, scapulohumeral dystrophy, and as well as distal myopathy, because there was no distal muscle involvement as well. According to presentation, patient underwent investigations which included CPK, electromyography, and muscle biopsy. So these are the investigations which are done in patient with muscular dystrophy, limb girdle muscular dystrophy. In our patient, creatinine kinase was mildly raised. Other blood investigations were normal, and electromyography was suggestive of myopathic pattern, which was confirmed on muscle biopsy. So, as our patient had diagnosis of limb girdle muscular dystrophy, let's discuss briefly about it. It is a genetically inherited disorder which mainly affects skeletal muscles, and it presents predominantly with proximal muscle weakness with loss because there is loss of muscle fibers. So its in prevalence ranges from 10 to 23 per 1 lakh population, with onset from early childhood from childhood to early adulthood. Most common calpainopathy subtype is most common subtype of limb girdle muscular dystrophy is calpainopathy, and other which is present in our patient. Other subtypes like dysparthenopathy and sarcoglycanopathy were ruled out on muscle biopsy. So calpainopathy constitutes about 40% of the limb girdle muscular dystrophy subtype, with geographical variance, and its prevalence is unclear. In India, it seems to be common form of limb girdle muscular dystrophy. Its inheritance is both autosomal dominant and autosomal recessive, with autosomal recessive being more common, 10 times more common than the dominant one. Its onset ranges from 5 to 20 years in 75% of the cases, and it can range from 2 to 40 years. And the phenotypes are femoral limb girdle muscular dystrophy, scapulohumeral limb girdle dystrophy, and hypercemia. And autosomal dominant variant has phenotype variability. So it can present from asymptomatic to wheelchair dependence after age of 60 years. So calpain-3 is a gene which is involved in calcium regulation in sarcomere. When its deficiency is there, there will be protein aggregation and impaired growth and atrophy, leading to muscular dystrophy. So patient will present with proximal muscle myopathy, usually at young onset, and there will be difficulty in running, climbing, and lifting weights. And there may be associated backache and myalgia. It will be present in most on the dominant form of the disease. As seen in our patient, on examination there will be presence of winging of scapula, paddling gait, and calf muscle hypertrophy can be seen, and there will be sparing of facial, ocular, tongue, and neck muscles, and heart and intellectual capacity of the patient. These are usually found in other subtypes of limb-girdle muscular dystrophy. So, because limb-girdle muscular dystrophy is a rare presentation in old age, we did literature search and found few case reports and case series. Here, there is a 70-year-old male who presented with sudden onset inability to perform everyday activity. He had difficulty in swallowing, and there was ptosis on examination. So, on muscle biopsy, diagnosis of oculopharyngeal muscular dystrophy was made. Here, in this case report, there are members of family who were found to have collagen 6 related limb girdle muscular dystrophy with age of onset 40 to 60 years of age. And here in this case report, patient was 77-year-old male who was having symptoms 10 years before the onset of the before the diagnosis of the disease, and he had despite having features of facioscapulohumeral dystrophy, he was not uh, evaluated genetically because considering the age of the patient, but when it was done, he was found to have the disease. As highlighted in this article, neuromuscular disorders are can present beyond age of 65 years, and they can be misdiagnosed as sarcopenia. So when a patient comes to us with sarcopenia, we should keep other differentials in mind and evaluate the patient further for the final diagnosis. This case series has included all the patients who were elderly and had genetic disorders. So they all, most of them had late onset of disease. Here there was a patient who was 84-year old, whose age of onset of muscle weakness was 50 years of age, and when she was diagnosed, her age was 84 years. She was diagnosed to have calpainopathy. And this is the same patient. Now, this increasing recognition of single gene genetic disorders in old age can be explained by following a point, like following explanation are there. First, there is increasing lifespan in general population. So, when it is not unusual to find these diseases later in life. Second is there is increasing awareness that the diseases which were primarily thought to be present in childhood can also present in adult and older patients also. So while diagnosing, we try to keep the differentials in mind and then evaluate the patient. And there is there is advance in DNA based diagnosis, genetic diagnosis. So this helps in the diagnosis of the patient. Coming to management, our goal of therapy should be maintaining mobility, functional independence, and managing associated complications and maximizing the quality of life. So our approach should be multidisciplinary, including physical and occupational therapy and orthopedicians and genetics. These are two case reports where they have shown benefit from physiotherapy in limb girdle muscular dystrophy patients, though it has been done in young patients. This first patient was 22-year-old female, uh, and this in this case report they have included 8 patients whose average age was 36 years, and they have been benefited from physiotherapy. Now I'd like to call Dr. Pramod sir, consultant geriatric medicine, for further remarks.
Thank you, Dr. Bhavna. In our clinical practice, when we see an older patient with a muscle weakness, we generally keep differentials of degenerative spinal disease or neuropathies or sometimes myositis, polymyositis, dermatomyositis, and occasionally MND. But in this case, we were really surprised to see that this patient presented with symptoms classical of limb girdle muscle dystrophy, and the onset was very recent. Just the duration was about 1 year. Uh, so we decided to present this case in the CCR. However, though rare, more and more cases are being recognized now as of genetic diseases, which usually used to be present in a young patient or a middle-aged patient, are now presenting in old age. As discussed above, it can be either because of the increasing longevity or because of the slow progression of some variants of the disease. For example, the autosomal dominant of variant of the calpainopathy may present late, and as clinician, we should have a high index of suspicion for these patients who present with symptoms of genetic disorder at very late age. And finally, the genetic for this genetic disorder, we should have a genetic assessment and genetic counseling. In our patient, genetic assessment was not done because he had to go home just before the wave 3 of COVID. He is from Nepal. So we are planning to do genetic analysis in the follow-up. So before ending, I would like to thank our colleagues from the neurology department and rheumatology department, and also from the colleague from the pathology department and radiology department who helped us to come to this diagnosis. So, and also I would like to thank our physiotherapy team who dedicated hard work resulted in a better outcome. The patient is at home and now he is symptomatically better and able to maintain his daily activities. So thank you again. Any questions or comment are welcome.